Hello people, this is Dr. Muskaan this side and I'm going to share a very interesting case with you. There was in my heart that I want to study one case of sepsis and today finally I have studied it. So I'm going to tell you the very simple procedure how to see it is SIR, then sepsis, then severe sepsis and then finally septic shock. So let me take you towards the journey of this case. Here is 53-year-old female who has came to emergency in hospital yesterday at 8:15 p.m. with chief complaints of fever associated with chills, vomiting. There were 10 to 15 episodes of vomiting, pain in abdomen and generalized weakness. There was no history of melena, hematomasis or loss of consciousness. On arrival, ABC was done, that is airway, breathing and circulation. Airway was patent. There were no signs of airway obstruction. What are the signs of airway obstruction, by the way? It is choking, inability to speak, inability to cough, difficulty in breathing, high-pitched sounds, cyanosis, or victim clutches his neck. So there was no sign of airway obstruction, but if the signs of airway obstruction are present, then we have to do intubation of the patient. Further, on breathing assessment, it was respiratory rate was 22 per minute, which was of course increased. There is tachypnea because normal respiratory rate of adult lies between 16 to 18 per minute. SpO2 was 98% at 6 liters of oxygen via NRBM, that is non-rebreather mask. When circulation assessment was done, pulse rate was 106 per minute, my dear friends. This is tachycardia because normal pulse rate is between 60 to 100 per minute. BP was 86 by 50 mmHg, which is hypotension. Now, sensorium was alert. GCS score was 15 by 15, E4, V5, M6. That she was opening her eyes spontaneously. Verbal response was oriented, and she was obeying command of motor responses. RBS was 52 mg per dl, my dear friends, and she has no history of diabetes mellitus in past. Further, let me take you through HOPI of this patient. Patient was apparently normal 3 days back when she presented with chief complaints of fever, sudden onset, progressive in nature, non-documented, high grade associated with chills relieved on taking medications. Patient also has vomiting which is non-projectile, non-bilious, non-blood stained containing only food particles. Patient complains of generalized weakness along with pain abdomen and upper abdomen. Now I have to rule out the negative history, so rule out some history. So negative history was there was no history of loose stools, with which I have ruled out one of the warning signs of the dengue fever. There was no history of shortness of breath, with which I have ruled out some respiratory disease such as pneumonia or ARDS. There was no history of bleeding manifestation, from which I have ruled out one of the main feature of dengue hemorrhagic fever. There was no history of burning micturition, from which I have ruled out UTI. There was no history of loss of consciousness, from which I have ruled out diabetic encephalitis. Further past history, there was no comorbidities such as diabetes mellitus, TB, asthma, epilepsy, thyroid or any other chronic illness, but she is known case of rheumatoid arthritis, my dear friend. She is known case of rheumatoid arthritis. Surgical history, she has been operated for open laparotomy 30 years back. On examination, the patient is lying uncomfortably on the bed. She is confused, non-cooperative and is speaking incomprehensible vocabulary. Vitals, BP was 115 by 70, pulse rate was 97 per minute, respiratory rate was 31 per minute, SpO2 was 98% on room air and temperature was afebrile. Parallel was moderate, clubbing was absent, edema was pitting edema, icterus was present and there was absence of lymphadenopathy. On systemic examination, per abdomen examination was done, which was soft, non-distended, mild tenderness on epigastrium. Now let me take you towards investigation picture of this patient. CBC shows there is anemia, thrombocytopenia, hematocrit levels were reduced. KFT shows hyperkalemia, hyperuricemia. LFT picture shows hyperbilirubinemia, serum transaminitis, hypoalbuminemia and increased level of ALP. When there is increased level of ALP, it indicates damage to your liver or one of the bile ducts that drain your liver, which becomes blocked. Now ABG picture shows metabolic acidosis with hagma. Further, I have seen SIR, that is systemic inflammatory response syndrome. Temperature was 96.6, respiratory rate was 31 per minute, heart rate was 97 per minute, WBC was 11,200 and PCO2 was 32.8. And from all this, I have seen there are more than 3 parameters which were positive for SIRS, because temperature अगर 100 से ज़्यादा हो या 96.8 से कम हो तो उसको SIR में लेते हैं। रेस्पिरेटरी रेट 20 से ज़्यादा होना चाहिए, हार्ट रेट 90 से ज़्यादा होना चाहिए, WBC 4000 से कम या 11000 से ज़्यादा होना चाहिए, PCO2 32 से कम था। नाउ फॉर सीइंग द सेप्सिस आई हैव सीन दैट देयर वर two parameters which are positive for SIR, and there was confirmed infection of dengue NS1 antigen test which was positive. That means this patient is in sepsis, क्योंकि sepsis देखने के लिए आपको देखना होता है कि कोई भी 2 पैरामीटर पॉजिटिव होना चाहिए SIR में प्लस इन्फेक्शन होना चाहिए। Now we were seeing the severe sepsis in which we saw that there was sepsis present, lactic acid का level 4 से ज़्यादा था, 4.9 मिलीमोल पर लीटर था, हाइपोटेंशन था पेशेंट को, एंड साइंस ऑफ एंड ऑर्गन डैमेज भी था क्योंकि पेशेंट वॉज डिसओरिएंटेड, देयर वर चेंजेस इन मेंटल एबिलिटी। So further septic shock कैसे था, there was severe sepsis with persistence, there was sign of end organ damage, hypotension and lactic acid level was more than 4 millimole per liter. So the diagnosis here is sepsis with septic shock. For the chest X-ray was showing bilateral pleural effusion, ultrasound shows cholelithiasis, thickened edematous gallbladder wall, mild ascites and mild bilateral pleural effusion. What was good and new thing was there was an investigation of peripheral smear which shows that RBC is normochromic teardrop cell which is found in iron deficiency anemia, my dear friends. WBC shows neutrophilia, platelet shows thrombocytopenia, and reticulocyte count was 4.5%. And when reticulocyte count is more, it shows there is recovery from iron deficiency anemia. Iron profile, when I have seen, there was decreased iron level, it was 18 microgram per dl, normal lies between 37 to 170 microgram per dl. So overall it shows that there is iron deficiency anemia, iron levels drop down है, teardrop cells मिल रहे हैं, pencil like cells मिल रहे हैं, which is typical feature of iron deficiency anemia, my dear friends. ECG shows right bundle branch block because I have appreciated M pattern in V1 and V2 leads and W pattern in V5 V6 leads. So overall diagnosis from this history was dengue fever with sepsis, with septic shock, with metabolic acidosis under evaluation. And what was the main learning objective from this case was हमें एक टैबलेट दे रहे थे दैट वाज मेथोट्रेक्सेट जो उसकी पहले से चली आ रही थी फॉर रूमेटॉइड आर्थराइटिस। नाउ मेथोट्रेक्सेट का एक साइड इफेक्ट है कि वो आरबीसी के लेवल को रिड्यूस कर देता है, एंड फॉर दिस वी हैव सीन ओनली दैट कि उसमें आयरन डेफिशिएंसी एनीमिया है। उसका ट्रीटमेंट क्या है, हमें आयरन देना है पेशेंट को, बट हम इस पेशेंट में आयरन दे नहीं सकते क्योंकि अगर हम आयरन देंगे तो वो एग्रेसिवली एक्ट करेगा, तो ये मेन चीज़ है इस पेशेंट में। That's all. I have really enjoyed learning on this case, and I hope you have also enjoyed listening to the history of the patient. Bye bye doctor. This is V1, this is V2, this is V5, this is V6. V1 में आपको M पैटर्न मिल रहा है, V2 में भी M पैटर्न मिल रहा है, V5 में देखो W पैटर्न है, V6 में भी W पैटर्न है, and this shows us this is right bundle branch block.